Hello, my name is Shashank Sinha, and I'm an advanced heart failure and transplant cardiologist at Inova Shar and Heart and Vascular at Inova Fairfax Hospital in Northern Virginia, where I'm an assistant professor of medical education at the University of Virginia School of Medicine and serve as the medical director of our cardiac intensive care unit in cardiology and director of the cardiovascular critical care research program. I recently had the pleasure and privilege to serve as chair of the AHA scientific statement entitled Evolution of Critical Care Cardiology, an update on structure, care delivery, training, and research paradigms. And I'd also like to invite my good friends, scientific collaborators, and mentors, and esteemed colleague, our Vice Chair, Dr. Bram Geller, and Senior Author and close mentor, Dr. David Morrow, to introduce themselves.
Hi there. I'm Bram Geller. I'm a critical care cardiologist at Maine Medical Center. I'm assistant professor of medicine at Tufts Medical School. I'm the director of the cardiac intensive care unit at Maine Medical Center and also serve as the director of the temporary mechanical circulatory support program. Thanks for having me on.
And I'm Dave Morrow, the section head of critical care cardiology at Brigham Women's Hospital and a professor of medicine at Harvard Medical School.
I'd like to thank both of you, as well as the American Heart Association, for commissioning this paper, especially our CLCD chair and vice chair at the inception of this project, Dr. Venu Menon at Cleveland Clinic and Dr. Abdullah Damlouji at Johns Hopkins, for their steadfast support of this initiative and also for serving as co-authors on this paper. And most importantly, we'd like to thank both Paul St. Laurent and Lacey Pinion, without whom their ardor, diligence, and persistence, this manuscript really would not have come to fruition. So first things first, why did we write this statement? And I'd like to kindly ask Dr. Morrow, as the chair of the 2012 AHA scientific statement on the evolution of critical care cardiology, to briefly comment on the origin story for that statement, as it really served as a seminal statement to inspire both Bram and myself, among countless others, to pursue critical care cardiology as a specialty. What inspired you, Dr. Morrow, to craft that original statement, and how have you felt the field has evolved over the past decade since you published this landmark document?
Yeah, no, I'm happy to comment on that. I'd say that, when we met to convene the writing group for the first scientific statement that was published in 2012, the field of critical care cardiology was truly in its infancy, and it was born out of really our clinical practice, where many of us practicing in cardiac ICUs saw a shifting epidemiology beneath our feet and recognized that the expertise and experience that was necessary to really deliver excellence in critical care was evolving. And so we undertook the 2012 scientific statement with the purpose of outlining several key areas: organization, staffing, fundamentals of care delivery in the CICU environment, training, and research. And I think since then, now more than a decade later, all of those things are still just as important as they were more than 10 years ago. The field has certainly is still maturing at a very rapid pace. The complexity of our patients, the complexity of the care that we provide and that we deliver in advanced cardiac ICU seems to be inexorably progressing. And so, I think it's a strength of this current update that it integrates all that we've learned over the last decade with more evidence and more experience in this evolving ecosystem of critical care cardiology, and comes back to the key foundation, which is that it's essential for us in our cardiovascular professional societies to lay out a roadmap. And I think this updated statement fulfills that crucial need again in what I think is a very exciting phase of continued growth and maturation ahead for the field. And we're all ultimately aimed at providing the best possible care that we can for our sickest cardiovascular patients.
Thanks, Dr. Morrow. As always, a very beautiful and eloquent preamble. And so with that background in mind, I'd like to share with our audience that our goals in this paper were really to provide a timely update, a contemporary perspective on the organizational structure, staffing, and care delivery in the contemporary cardiac intensive care unit, examine challenges and opportunities that are present in our educational and training environments, particularly for the next generation of physicians for critical care cardiology, and then explore quality improvement initiatives and scientific investigation, including multi-center registries like the one that Dr. Morrow leads, as well as randomized clinical trials that hopefully have the potential to change clinical practice, care delivery, and the research landscape over the next decade. So I think no better way to explore the key takeaways from this paper than walking through some of the main figures. And Dr. Geller, perhaps you'll indulge us and get us started by tackling figure 1, which you conceptualized and brought to fruition. But how do we achieve optimal patient outcomes in a level 1 CICU? And really in 2025, what should an AHA level 1 CICU look like?
Yeah, I think this is a really high yield topic. I think I would refer our listeners to table 1 in the actual manuscript, where we go in very great detail into the staffing and structure of an optimal level 1 CICU that's probably too detailed to share in this format, but I think would be very high yield. In figure 1, we try to capture the high points of many of the things that are discussed in that table 1, where we're really focusing on how do we actually achieve optimal outcomes in a level 1 CICU. And we talk about leadership from a critical care cardiologist, nursing ratios of 1-to-1, the importance of an interdisciplinary rounding team and an interdisciplinary team in making medical decisions. And we talk about the devices and procedures and things that really the expertise of a critical care cardiologist can bring to a level 1 CICU. But the responsibilities of the physician leader and a cardiac intensive care physician really extend beyond that. And I think in figure 2, Dr. Sinha, we nicely highlight many of those things if you want to share that figure.
Yeah, thanks very much, Bram. Figure 2 highlights some, and I will say far from all, of the myriad roles and responsibilities of a critical care cardiologist, whom I think in, again, 2025 and beyond is ideally well suited to address a myriad of important roles and responsibilities across the spectrum of patient care, education, safety, quality, and research. Perhaps there's no greater example than the recent COVID-19 pandemic in showing the many ways in which a critical care cardiologist can contribute to a hospital or health system, not only in cardiac ICUs, but also medical ICUs and many other critical care units, and lead their collaborative and interdisciplinary teams, engage in quality improvement initiatives, lead scholarly investigation and other research efforts. And then I think a sine qua non for moving forward in our field is really to foster the pipeline and really walk the walk when it comes to diversity, equity, inclusion, and other efforts as a core focus of our discipline. So now back to you, Dr. Geller. Can you comment a little bit on training pathways for critical care cardiology and how they have evolved since you embarked on this endeavor? Which one did you ultimately choose and why? And then let's embellish a little bit on what are some of the exploratory training pathways that are being considered as we discussed briefly in the manuscript?
So in figure 3, we highlight some of the training models for trainees interested in critical care, and there's quite a few possibilities in different directions trainees can take depending on their interest and the sequence they want to do things. In figure 3, the top training is one of the common training pathways where somebody trains in cardiology and then spends 1 or 2 additional years training in critical care cardiology. The second option is doing critical care cardiology first, followed by later cardiology training, which is 2 years in critical care and then 3 years in cardiology. And then there's some other models that involve additional subspecialty training in advanced heart failure or interventional cardiology that also exist. And in the bottom portion of figure 3, we highlight some proposed training paradigms of the future where cardiology and critical care aren't isolated, distinct fellowships, but they're kind of merged into one. And training from day one can focus on both cardiology and critical care cardiology. When I was in training, I ended up doing that first option, meaning cardiology followed by critical care. I debated about doing an additional subspecialty training, but in the end felt like I really wanted to devote my career to critical care cardiology. And there's some complexity in continuing expertise in multiple subspecialties that I thought would be challenging. And so I did cardiology followed by critical care, and I think that pathway for me worked well. But I think this figure well illustrates that there are other pathways, and I think depending on interests and availability, some of these may make more or less sense for an individual trainee. And then in figure 4, we highlight what about those folks that don't necessarily want to do extra years of clinical training and want to have a practice focus in cardiology without true kind of dual board certification. And this kind of training, I think, lends itself really nicely to level 2 CICUs. And I think in the prose of the manuscript, we highlight some of the advantages of such a model. But here we highlight how the third year of general fellowship can be spent really focusing on key concepts in the CICU and either doing that practice focus with or without another advanced subspecialty. And folks who get this training are then well prepared to work in level 2 or 3 CICUs and work collaboratively potentially in level 1 CICUs with critical care cardiologists as well.
To build on some of the changes that have occurred over the past decade as we round and take care of these patients, I'd love if you could expound further on figure 5, which is really inspired from the work you've done at Brigham and Women's Hospital in leveraging the electronic health record to design real-time quality improvement dashboards for hopefully mitigating potential complications and taking care of the very critically ill cardiac patient. Could you share your thoughts on that as well?
Yeah, this figure is an important one to me because it emphasizes really three critical aspects. One is the importance of safety and mitigation of complications of the advanced care that we're providing. And I think I'll ask Bram to comment on that in a second because he's spent a lot of time thinking about this. The second is that we need to and should be able to harness the vast amount of data that we already collect in our EHRs in the course of our routine care for predictive analytics and for hopefully even improved diagnostics. But at least at present, we can use it to provide more real-time support for implementation of safety measures. And that's what this figure illustrates is a real-time dashboard that we had created so that we could track over the course of a day our discussion from rounds and how well we were doing in implementing the plans to try and preserve safety and mitigate complications of the care that we're providing. And I think from that perspective, it's just one example, really just the tip of the iceberg in terms of things that we could do leveraging the EHR in better processes of care to hopefully improve outcomes in ICUs. Bram, I'd love for you to expand a little bit on what you think about in terms of safety checklists in the ICU and what principles that should be really driving what we do around safety in the cardiac ICU.
Yeah, and I think some of this stems from a previous scientific statement led by Dr. Fordyce that was an American Heart Association statement published in 2020 about preventing complications in the CICU, because a lot of the therapies that we use in the CICU, whether it's mechanical circulatory support, inotropes, ventilation, CVVH, all those things are beneficial for our patients, but carry with them their own risks. And I think to really optimize and achieve the best outcomes in level 1 CICUs, but really all CICUs that take care of complex cardiac patients, we need to be mindful about how we mitigate these complications, look out for them, address them, and make sure that we can use checklists and dashboards, as Dr. Morrow was discussing, to make sure that we're kind of using all the principles that we know and applying them to each patient every day, because We know patients in the CICU are incredibly dynamic and things change on a day-to-day basis, and it's very easy to miss some of these checklist type items. But we know from robust data in medical ICUs and other ICUs that if we're able to maintain a lot of these checklist items, that it optimizes outcomes and improves patient mortalities in the CICU.
Yeah, I think it's worth emphasizing that point, and that much of what we tackle in the scientific statement is based on the expert integrated experience of a broad interdisciplinary author group. And in some ways, much of it is forward-looking based on our experience. But this is one of the areas where we have the strongest data
Yeah.
set from across the spectrum of ICUs to know that we can improve outcomes with these specific safety measures that fall under the A, B, C, D, E, F categories that have been used in general ICUs. And then I think the other area that has really progressed from 2012 is that the data that drove us toward high intensity staffing models in general ICUs, we now also have data in cardiac intensive care units, which we did not have when we wrote
Yeah.
our statement in 2012. And we now have data from multiple studies, at least 4 studies that have supported that the high intensity model that you described earlier, Bram, is one that also is associated with improved outcomes. And those are 2 evidence-driven areas that are core of the statement.
So for any trainees that are out there, strongly consider critical care cardiology. It's now a rapidly evolving specialty that really across the spectrum at both academic and community centers is highly engaged and is desperately needed. And so we welcome you, and we hope to collaborate and work with you to solve these ever-pressing problems. So with that, I'd like to thank our entire writing committee, all our co-authors for their invaluable contributions to this manuscript. It truly was a labor of love. And we hope this conversation has piqued your curiosity and interest in our paper, and we welcome your candid feedback. And on behalf of the entire writing committee, thank you for your time and attention.